Up next, Dolph Hutter and Dr. James Douketis, professor of medicine at the McMaster University in Hamilton, Ontario, Canada, discuss what is the evidence for bridging prosthetic valve patients for non-cardiac surgical procedures.
Jim, welcome to ACCEL.
It's my pleasure to be here, Dolph.
This is a very bread and butter topic, and maybe we can break it down for our listeners. Why don't we talk about which valves? Is there a difference between valves in terms of needing the bridging?
Sure. Certainly patients who have mechanical bileaflet aortic valves, there's increasing evidence that they do not need to be bridged. On the other hand, patients with a valve at the mitral position, irrespective of the type, whether it's an older type or a newer one, I think those should be bridged.
Even if they're a normal sinus rhythm, which would be unusual in the mitral valve position, you'd still bridge them?
Yes, I would.
Okay. And in terms of the aortic valves, now you're not talking about the older ball valves, the Starr-Edwards valves. You're talking about the newer bileaflet valves.
The newer bileaflet valves, St. Jude, for example, there is an increasing evidence that those can be safely managed without bridging them during warfarin interruption.
Now, what about, suppose they have a bad heart, they have a low ejection fraction, and they have heart failure. Would that influence you at all?
Very much so. So when I'm referring to patients who do not need to be bridged, I refer to them as having uncomplicated mechanical bileaflet aortic valves.
So in those patients, then you would allow the INR to drift down to normal before a major operation?
Yes, I would.
Okay. What about the procedures? Is there a difference for different types of procedures?
Indeed, there is very much. There are a number of procedures where you don't really need to stop the warfarin completely. You can drift it down so that the INR is between, let's say, 1.8 and 2.3. And here's the procedures I mean. Minor dental, skin procedures, cataract surgery, largely avascular. In the cardiology realm, patients having pacemakers or ICD implantation, or those having cardiac catheterization, especially by the radial artery route.
Does that individualize with the interventionalist? In other words, does some of them like an INR under 1.8 or something like that? Is that a variable target?
There is going to be some individual discrepancy, but the literature says that if you have an INR in the lower therapeutic range, so again, between 1.8, let's say, and 2.3, then you can safely undergo those procedures with a minimal risk for major bleeding.
You made a very important point, the radial artery versus the femoral artery, and that's because of the decreased bleeding with radial artery?
Yes, that's correct.
Okay, and that's been pretty well established.
I think so. There is increasing evidence to support not stopping warfarin in those patients.
And more of our colleagues in the interventional laboratory are comfortable doing radial artery procedures now.
Yes, I would agree.
We're talking about warfarin so far. And sometimes, as you say, you like the INR about 1.2 if you're going to have a major abdominal or intrathoracic procedure, drifting down to that level before for other procedures. What's the role of the new oral anticoagulations, the so-called NOAC, in prosthetic valve patients?
In short, there is absolutely no role for these new oral anticoagulants in patients with either a bioprosthetic or in a mechanical heart valve prosthesis.
Very important point. In fact, that's been studied, hasn't it?
Indeed. There was a recent trial that looked at dabigatran in patients with mechanical heart valves that showed an increased risk of both thrombosis and bleeding, leading the trial to be stopped prematurely.
Okay, so stay with warfarin if you have a bioprosthetic valve or a mechanical prosthetic valve.
It's going to be here for a while yet.
Jim, those are excellent points, very well stated. Thank you very much.
Thank you.